Hey guys, welcome back. The topic we're going to study today is fat embolism syndrome. In fact, there are two terms that you will encounter. One is going to be fat embolism, second is fat embolism syndrome. So with majority of orthopedic procedures, especially the ones which are related to nailing in the bone, there can be fat embolism, but the inbuilt systems of the body is going to prevent the development of fat embolism syndrome in the patient. Now let us look at what actually happens in fat embolism syndrome. Subsequent to polytrauma, like this person had a fracture of the shaft of the femur, fat globules will be released in the circulation. These fat globules are then going to cause release of free fatty acids that will damage the alveolar endothelium. Therefore, there would be alveolar edema, there would be damage to the brain capillaries, so there is going to be stupor and coma. And most importantly, we also have development of petechiae in these patients, which are predominantly seen around in the axilla and the chest area. In fact, what I described before you at the moment are the three important Gerd-Wilson criteria which are useful for diagnosis of this particular condition. Subsequently, I will explain the minor criteria to you as well. So let us discuss this as a case-based scenario. Let us assume this is an 18-year-old guy and he was given a Harley Davidson or a Bullet or any other heavy-duty bike by his father on his 18th birthday, and unfortunately he had a biking accident. Now, luckily, he was using a helmet at that particular point of time, so he did not sustain any head injury. But because the bike fell on the leg of this guy, so there has been fracture of the shaft of the femur, which is going to cause release of fat globules into the circulation. This guy was rushed to the nearest hospital where the best orthopedician of the city operated upon this guy. So surgical intervention for the fracture of shaft of femur, it was, I would say, maybe a fracture that had even caused extensive damage to the soft tissue, and maybe the part of the bone was jutting out. But this guy has been operated upon, he has been taken well care of. Unfortunately, post-operatively, approximately about 12 to 72 hours later. And why I'm calling it unfortunate is because if fat embolism occurs, it becomes very difficult to explain to the relatives why there is a sudden deterioration, because they're obviously not technical people. They don't understand what fat globules or free fatty acids or what's going to be the damage to the endothelium or the vital organs going to be. So post-operatively, what we are noticing is this guy is having sudden onset breathlessness. And well, the nurse noticed that this person was breathless, so she has started this person on high flow oxygen and gave a call to the orthopedician who had operated upon this person, let me say yesterday. But the orthopedician said, well, I'm a little busy in the OT, so let me finish a case and I will come. But if the orthopedician takes a few hours to come, and most of the time that's going to be the case, because obviously he would not be free at all the times to attend to every case. So by the time he finishes his case and comes, it might be actually too late. Why? Because in this particular case, the free fatty acids are going to damage the endothelium of the brain as well. They can be cerebral edema manifestations. So initially, it's a possibility that this person may not be recognizing his parents. He may not be recognizing that you are a healthcare worker. He might be having cognition defects. Subsequently, in fact, these patients can go into coma and you might even have to intubate the patient. Now, for the parents, this is obviously going to be a big shock, because initially this guy, post-operatively, he spoke to his mom. He said, Mom, I had this accident. I'm fine. Please don't worry. And now he's not able to recognize his mother. And at the same point of time, the nurse is putting him on oxygen. And now he's not even opening his eyes and he's not even recognizing anybody. So the point is, when there's a sudden deterioration, obviously the relatives will go into a panic mode and they will obviously contribute to problems for you as well. Not only from the perspective that they might be rude to you, but even you would be wondering what really suddenly happened. If you carefully examine this patient, you will notice that there will be also presence of petechiae. These petechiae are usually noticed fairly late, because see, post-operatively, because the patient's upper part of the body may not be exposed by you for the entire physical examination, because you don't want to cause any discomfort to the patient. So you may not actually examine the axillary area of the patient, but subsequently these petechiae will spread all over, including over the chest, in the front, back, and even on the extremities as well. Well, as I said, what I'm describing before you are technically called as Gerd-Wilson criteria for diagnosis of fat embolism syndrome. And while describing these, I also want to say that you must be very, very careful while attempting the MCQ, because one of the important differential diagnoses of this condition is pulmonary thromboembolism. You see, if I gave you a case scenario where a patient has been immobilized. Like this particular chap, he was, let me say, not driving a bike, but he was crossing the road when a car hit him, and he unfortunately fractured his tibia, or maybe both the tibia. Now he cannot walk. Any patient who's immobilized, like a case of bilateral tibial fracture, or it could be even a lady who's recently given a delivery or has had a baby post a cesarean section. So my message is, any patient having prolonged immobilization for 2 to 3 days, complete bedridden, there could be development of clots in the soleal veins, and these clots on the soleal veins can then embolize from the primary side via the inferior vena cava to the right side of the heart and then into the pulmonary circulation, contributing to pulmonary thromboembolism. The message is, pulmonary thromboembolism will also present with respiratory distress, but there will be no CNS manifestations in these patients. I mean, you're not going to have a development of a fast onset coma in a patient of pulmonary thromboembolism. Yes, hypoxia can contribute to a bit of drowsiness, or initially the patient might be even having aggressive behavior, because hypoxia initially makes a person angry. But you will not have coma, you will not have petechiae. So you must always consider this in the differential diagnosis before you comment on the diagnosis of fat embolism syndrome. So I mean, every time you read a question related to trauma and there's a respiratory distress, you obviously have to think not only in terms of fat embolism, but even in terms of pulmonary thromboembolism. And one more differential, in fact, I can mention right at the moment. I mean, traditionally I describe a differential when I'm completed a topic, but here what I'm saying is, because in the exam he is going to ask you to make a diagnosis on clinical grounds. So there can also be pulmonary contusion written in multiple choice question. Now, pulmonary contusion will also occur after trauma, but most of the time the respiratory distress of pulmonary contusion develops as early as 6 hours. When I was describing fat embolism, I was giving you a relatively longish time frame, something in the middle, something like 24 hours, I would say, from a range of 12 to 72. But in pulmonary contusion, respiratory distress is relatively early, and when you do a X-ray in a patient of pulmonary contusion, you will notice that there would be localized, I mean, whichever lobe of the lung is the one which is traumatized, you would be having localized ground glass opacities. In contrast, when it comes to pulmonary thromboembolism, I've described about radiological findings like Hampton's hump, which would be very characteristic and would be easily identifiable. Or you can do a CT angiography in a patient and you would be able to see a big saddle embolus, which is obstructing the pulmonary artery at its bifurcation, contributing to hypoxia, contributing to ventilation perfusion mismatch in the patient. So once we are clear about these two differential diagnoses which have to be kept in mind, and I want to highlight once again, it is not the duration that matters, it is the antecedental and the concomitant information that is given in the question. Let's have a quick look at what really happened in this case, though I have shown you an animation in this case, which is a new addition in our I would say the PL 4.0 edition, and our objective has been to introduce the visual memory component, or rather enhance the visual memory component of your brain. So this is what I said. Ultimately, fat globules have been released. You can take this as a representation of the shaft of the femur. This is going to be acted upon by LPL, lipoprotein lipase, which is going to contribute to generation of free fatty acids. The bad guys here are free fatty acids, because they are the ones which will be damaging the capillaries which are surrounding the alveoli. As a result of the damage to the pulmonary endothelium, two things will happen, and listen to these words very carefully. I am not saying that there is any increase of hydrostatic pressure in the pulmonary vessels which will cause leakage of fluid. I am saying there is a physical damage to the pulmonary endothelium. So there is going to be leakage of fluid out of these blood vessels into the alveoli. There is going to be ultimately a alveolar edema occurring. And along with this alveolar edema, we also find alveolar hemorrhage, because after all the blood vessels are damaged, so there would be bloody fluid present. So alveolar edema and alveolar hemorrhage will explain why are these patients going to have development of respiratory distress. The SpO2 the patient is falling, and initially any hypoxic patient will be angry and he'll say, do something doctor, I'm not getting breath. But gradually as the oxygen levels will fall, you will notice that the person's ability to recognize his vision component, everything would be compromised. So ultimately what's happening is that free fatty acids and the damage to the pulmonary endothelium will cause release of cytokines. And now we reach an important part of our discussion. I mean, don't just dismiss that, okay, there is release of cytokines which are contributing to ventilation perfusion imbalance. That is understandable. You have to understand why is it that these patients are also having CNS manifestations. So I want you to understand or listen to my next points very, very carefully. I want to tell you that approximately 20 to 30%, mark my words there, I'm not saying 20 to 30% of the world population. I'm saying 20 to 30% of those cases who are having fat embolism syndrome are having CNS manifestations. So the query of most of the doctors is that, sir, after all the cytokines and the free fatty acid, they're damaging the lung endothelium. So how do they end up on the left side of the heart so that from the left side they will go into systemic circulation? I mean, are you telling us that the fat globules can traverse by the capillaries and come to the left side of the heart? Well, that is obviously a possibility, but most importantly, they've demonstrated that in 20 to 30% cases of fat embolism syndrome, the patient might be having a patent fossa ovalis. If there's a patent fossa ovalis present, the incidence of CNS manifestations is approximately 20 to 30% of the total cases, and these patients have been documented on transesophageal echo to have a patent fossa ovalis, because of which there can be the passage of fat globules directly into the left side of the heart. And once they go into the left side of the heart, then they will obviously be thrown into the systemic circulation. And once they go into systemic circulation, that is when the brain will also be involved, and the capillaries of the brain will also be affected. So I want to highlight these facts that in approximately 20 to 30% cases, not of the entire population of the world, there is the PFO, but in cases who have developed fat embolism, PFO has been documented on TEE. Therefore, cerebral circulation will be affected. You will initially have cognition issues, stupor, and then subsequently development of coma, for which the person will definitely require intubation. Why intubation? Because I can say like this, that any person who cannot maintain his airway, there is a high risk of aspiration pneumonia developing in this patient. So CNS manifestations will start occurring. As I mentioned even in the starting of the discussion, I said if a patient is undergoing any kind of orthopedic procedure, like if a patient is undergoing a intramedullary nailing, even then fat embolism can occur. No issues with that. But somehow the critical mass of fat globules, the critical mass of lipoprotein lipase contributing to free fatty acids is not generated to trigger all the manifestations that I'm saying. So a large number of, I would say, cases will definitely be present, but they never come to clinical limelight, or they never come to clinical attention. So I've written asymptomatic fat embolism syndrome can also be present. I mean, this looks like a very surprising term, asymptomatic on one hand, and gross manifestations where the patient's relatives are ready to, fight with you. So very two diametrically opposite things that I've said, but both are a possibility. You need a critical mass of cytokines being produced, critical mass of free fatty acids being generated, so that the manifestations will occur. The usual cause, as I highlighted in the initial part, is going to be polytrauma. So we not only find that it is fracture of the long bones, but even the pelvic fracture, which is usually seen in road traffic accidents, can contribute to this manifestation, apart from the hemorrhage component that it can be associated with. Another important cause to be remembered, though I will say that majority of MCQs will describe trauma, even pancreatitis has to be kept in mind. Then is diabetes mellitus. Very surprising. A lot of guys, they message me and say, sir, how did you say diabetes mellitus contributes to fat embolism syndrome? So I just want to say that in people who are having diabetes mellitus, anyway, triglycerides are very high. So when triglycerides are very high, lipid profile is grossly deranged. Triglycerides in diabetes can be shooting beyond 500 mg/%. So this kind of a deranged lipid profile can not only contribute to diabetic patients developing acute pancreatitis. Listen to my words carefully. I said hypertriglyceridemia. Hypertriglyceridemia is an independent risk factor for acute pancreatitis. Hypertriglyceridemia is also a documented risk factor for a person having fat embolism manifestations even without trauma. That's the surprising thing. Then post joint reconstruction surgery, orthopedic procedures nowadays, you will notice that these are computer navigation aided, but in spite of that, joint reconstruction surgery will involve a bit of hammering, chiseling. You have to remove the old head of femur and deploy an implant. So because of all the drilling and the chiseling that is going on, again, fat embolism manifestations can occur. Then you will notice a lot of people who are going in for I would say cosmetic surgery, liposuction. I'm not talking about bariatric surgery, which is a definitive method of losing weight. Liposuction, just to get rid of the pot belly that a person is having, because the BMI is on the higher side and person wants to look relatively better. So tummy tuck is the casual word that people might be using for this liposuction and remove the centripetal obesity component. Then this liposuction, again, when they sign the consent form, it is written that fat embolism can occur. If a patient is very sick, for example, if a patient is having total parenteral nutrition being received for since he had extensive burns or he had a massive GI surgery, then even parenteral nutrition, you are giving fats into the body. So some component of that can definitely contribute to free fatty acid generation, and again the cytokine production can occur. The next part is actually not seen by we civilian doctors, but is seen by doctors who are in the Navy, that is decompression sickness. In decompression sickness, when a diver is coming up from, you see, when he's like 100 meters below the sea level, they are instructed to gradually come up. If a diver gets panicky, suddenly he spotted a shark, and a diver, he's maybe a rookie, a new one to the job, and he got very panicky. So when he will try to come up very fast, not only there's going to be precipitation of nitrogen bubbles, which will contribute to cerebral hypoxia, which will cause blockage of the coronary circulation, causing chest pain. But apart from nitrogen bubbles causing blockage physical of important organs of the body, you could also be having fat embolism that is occurring. So alternative name for decompression sickness, as you know from your physiology books, is Caisson's disease. I want to repeat this fact once again. Traditionally, with decompression sickness, you read about nitrogen bubbles contributing to physical blockage of the coronary circulation, or let me say the kidney circulation. So obviously patient can have abdominal pain, flank pain, chest pain, but along with this even fat embolism have been documented. So what I have done here is just described causes of fat embolism to you, and you will again notice that traditionally when I describe a topic, I start with causes, then with clinical manifestation. But this particular topic, you see, the question when it will be given to you, the framing of the question will be given in a fashion that he wants you to get diverted and start thinking in terms like pulmonary thromboembolism and pulmonary contusion. So you have to keep that in focus. And obviously if he mentions any of these terms initially, he says patient underwent a liposuction, patient underwent a post joint reconstruction surgery. I wrote the word injury here to initially highlight the fact that during joint reconstruction surgery, even if it is robotic, even it is computer navigation aided, still some injury can occur with the hammering and the chiseling that is going on, because you need to remove the old head of femur, deploy in a new one. So related to that, that's why the injury word initially came up. So if you are having any of this information that I have highlighted currently on the board, I put the entire thing in the domain of yours just to highlight that if any of these points are given, anyway you will be more confident in answering as fat embolism syndrome in a patient. Just to set the record straight, I'll just give you some figures also. They've documented the fact that even when it comes to polytrauma, listen to my words again very carefully. This time I'm not saying that a person is having any routine orthopedic procedure. I am saying if a person is having polytrauma, the incidence of fat embolism is as high as 90%. Shocking, right? But fat embolism syndrome incidence is approximately 2%. This highlights the fact that what I was saying initially, that human body has huge powers of healing itself. Every time something goes wrong in our body, every time there are cytokines, every time there's going to be, I would say, free fatty acid generation and damage to the capillary endothelium, the body will try to set things right. So even if you have fat embolism, that does not prove the fact that somebody will be having fat embolism syndrome. And that is the reason why these criteria have been devised, so that we are very, very sure about our diagnosis and we can start treatment of our patient accordingly. And if, you make a wrong diagnosis, it was pulmonary thromboembolism, you could have saved the patient by doing either a thromboembolectomy or going in for thrombolysis. If it was pulmonary contusion, the guy will end up in ARDS. So you could have actually intubated the patient and put him on a ventilator protocol, so that at least the chances of this patient expiring could have been minimized. So my point is that if you deploy the criteria properly, you will be able to make a more accurate diagnosis of your patient. So let's have a look at the major and the minor criteria. Since the major ones I have already spoken about, I'll write them subsequently. But initially we will now begin by describing the minor criteria that you will notice. On vital examination, there will be a tachycardia. The patient will also be febrile. So this is supportive evidence that you will notice being given in the question. Then if you do a fundus examination, important part to be done for diagnosis of fat embolism syndrome, you will be able to see retinal changes. Now, what kind of retinal changes can be anticipated? One would be the break in the column. Like you can see the retinal circulation, you can see the retinal arteries. The fat globules will be physically blocking the retinal circulation. That's one of the manifestations that can be present. Or in fact, there could even be retinal petechiae. Repeat the fact once again. Either it could be that retinal artery per se is having a breach, that is the fat globules are causing a physical blockage, or by that matter of fact there could even be petechiae noticed on fundus examination of the patient. Then the fat globules will be affecting the kidney circulation as well as the liver microcirculation. If the kidney circulation is affected, this same patient, you will notice when the record of input output, you will notice that the output of this patient is substantially reduced. Normal urine output should be 1 ml per kg per hour, but for past few hours the urine output of this patient will be substantially reduced. I mean, anuria, oliguria, will be talking about entire 24 hours. I'm saying even if you look at the output monitoring of this patient for the previous, let me say 3 hours, 4 hours since he had an onset of symptoms, a drop in the urine output of the patient will be noticed. The damage to the liver circulation will contribute to icterus. This finding may actually be missed because the patient was lying with his eyes closed. So in any comatose patient, obviously eyes are closed, so you might actually miss it. So you just need to open the eye and you will notice the unmistakable yellow tint of the sclera which is present. Hematologically speaking, there will be a sudden drop in the hemoglobin values of the patient. What you compared with the initial report, like you always do a complete blood count pre-operatively. So if you look at the CBC of this patient pre-operatively and post-operatively, the hemoglobin is reduced. So initially you are thinking this guy is having internal bleeding, but simultaneously other features are also developing, like the involvement of the kidney or the involvement of the liver. There's a thrombocytopenia occurring, and which explains the petechiae component. And because it's an inflammatory state, the ESR of this patient will be very high. I mean, going up to 80s, 90s, even going up to 100 as well. In fact, fat is the main villain which is responsible for this problem. So you could also be having fat globules present in this person's urine and sputum. I said a big thing, man. I said fat macroglobinemia. Fat globules could actually be demonstrated. I mean, if you send a urine specimen of this patient or a sputum specimen of this patient to your friendly pathologist, they can deploy special stains like Sudan black for fat. So I mean, they can deploy the special stains to actually identify the fat globules. And why is this a minor criteria? I mean, your query would be, sir, if you consider that this is such an important finding, then why did you mention that this is a minor criteria? That is because fat globules in the urine, you see, fat globules in the urine can be written as oval fat bodies. And you will read about me saying oval fat bodies in nephrotic syndrome. I repeat the fact once again. Every time you will read the literature on nephrotic syndrome and nephrotic range proteinuria, you will also read about oval fat bodies and fat macroglobinemia. Similarly, chyluria, filariasis, there is again lymph, and lymph would be, having digested fat. So fat globules in the urine can be present even in chyluria, even in a case of nephrotic syndrome, which is the reason why I can highlight the fact that this would be a minor criteria. The major ones we can summarize once again for practice, though they have already been talked about. The first and the foremost would be involvement of the lungs of the patient. Then can be central nervous system involvement. And third I highlighted was the petechiae. Most of the time, accessory muscles of respiration will already be in use by the time the orthopedician or you or a physician is attending to this case. And along with this, the patient would have already gone into coma. I also want to highlight that if he says what kind of respiratory failure is present in these patients, then initially the person will be having type 1 respiratory failure. Why? Because he is hyperventilating. But if you're not able to diagnose the case, or if supportive treatment is not given to this person, then there will be respiratory muscle fatigue. Respiratory muscle fatigue will trigger type 2 respiratory failure. I repeat once again, that's a standard norm with all cases in respiratory system. COVID-19 pneumonia, when they come to you initially, they are hyperventilating. So type 1 respiratory failure. If they are not getting a hospital bed like we had in March, April in India, people dying in their cars, because they could not secure a hospital bed. That's gonna be respiratory muscle fatigue, and that would be type 2 respiratory failure. Similarly, in asthma, acute asthma is type 1, status asthmaticus and impending respiratory failure. I mean, asthmatic has been breathing heavily since the whole night. He could not secure a hospital bed, so he goes into impending respiratory failure. The chest is totally silent. That's when you're gonna be having development of type 2 respiratory failure. So for diagnosis of fat embolism, you need to have a high index of suspicion. It should be presence of one major criteria. Remember my words very carefully. One major criteria like a CNS issue or a lung issue or a thrombocytopenia, along with 4 minor criteria. And I also want to say that don't be too rigid while deploying this criteria. Like suppose in the patient at the moment only 1 major and 3 minor or 2 minor are satisfied. You are not gonna say that okay, when all the 4 will appear, that is when I'm gonna make a diagnosis and start treatment of the patient, because by that time it might be too late. So a patient who's, let me say, febrile, and at the same time he's having a slightly decreased urine output along with features like low hemoglobin, low platelet count, which you know the laboratory reports are going to take some time to come back to you. So I don't need to be rigid with this one. You need to be sure, obviously, one major criteria has to be present, but for 4 minors, because some of them are laboratory criteria, laboratories take their own sweet turnaround time. You very well know technicians, they may not be following the deadlines that you offer them, that okay, I want an early report. So you don't need to be ultra rigid in deploying this criteria. Treatment has to be started up, and we will now talk about what is the minimalistic workup that must be done in this case. If a patient is done a chest x-ray early in the part of the disease, there will be absolutely no findings. X-ray can be normal. But in the subsequent part, because there will be alveolar edema, because there would be alveolar hemorrhage thanks to the injury to the alveolar capillaries, the ones which are lining the alveoli per se are damaged, and there is a leakage of fluid into the alveoli, that's when diffuse infiltrates would be present. That is why nowadays they recommend going in for a CT chest, a helical CT. And once you do a helical CT chest of the patient, you might be able to notice the same diffuse infiltrates that might be referred as ground glass opacities. Obviously, considering nowadays scenario, COVID-19 testing would be done in a patient, rapid testing can be done, and the rapid testing would turn out to be negative. But then ground glass opacities on a helical CT in the setting of trauma, I want to highlight the statement that I have said. Why? Because you see ground glass opacities in the lower parts of the lung, especially in current scenario, COVID-19 is anyway to be considered. The second thing that I would like to do in this patient, after evaluating the chest of this patient, either with the chest X-ray or CT, whatever facilities are available, is a CT head. CT head is anyway to be done because the CNS changes which are occurring in this patient should not be because of CNS hemorrhage. No, he could have actually fallen down from the bike and he had a subdural hematoma or a extradural hematoma, which is subsequently expanding in size, and now it is producing a mass effect. So when I did a CT scan of this particular chap, there was no evidence of any kind of CNS bleeding, no intraventricular, subdural, extradural, any kind of bleed was not present in this patient. If you do a CT head, in some cases, though in the later part of the illness, there might be a diffuse white matter petechiae. However, do not give too much of importance to the statement that I have said at the moment. In majority of cases, both the X-ray and the CT head would be normal. Transesophageal echocardiography facility may not be available in routine hospitals. So I'm talking about ideal scenario because you need to demonstrate the presentation of patent fossa ovalis, which can explain the movement of the fat globules from the right side of the heart to the left side and then into the systemic circulation. Doppler must be done. Doppler anyway would be available. Why I want to do a Doppler is because I want to rule out deep vein thrombosis. So I'm talking about Doppler of the extremities. I have already explained to you that one of the important differentials of any chap who's immobilized after surgery, it could be orthopedic surgery, non-orthopedic surgery, is development of clot in the soleal veins and embolization to the lungs. There's a separate lecture on pulmonary thromboembolism. Do listen to that. And when you listen to both the lectures, you will notice, one after the other, you will notice the stark contrast that both manifestations present as, and therefore are easier for us to identify. Then again, from the perspective of an institution, a research institution, let me say bronchoalveolar lavage can be done, and this bronchoalveolar lavage can then be stained with stained for fat. So you might be actually in the exam from an ideal perspective being given a lung specimen. Like unfortunately the patient died and this would be a lung specimen which was stained with oil red O. So you will be able to notice the presence of fat globules which were occluding the lung circulation primarily. But investigation number 3 and investigation number 5 are mainly from, I would say, institutional perspective. Otherwise in clinical practice, because we don't have all of these facilities, it is the Gerd-Wilson criteria, as I've highlighted, which are primarily to be deployed. And in Gerd-Wilson criteria, you will notice that none of these investigations were included. You very well have seen that I have not included. I have not said that you must be doing a CT head in the patient. I just said you need to demonstrate a coma, but coma has so many reasons. So if he says that you are able to deploy these criteria, supportive evidence from the workup, you are ready for treatment of this patient. There is no definitive treatment for this condition. What is the first step? Because there's a drop in the oxygen saturation, there is respiratory distress, so you can be using a non-rebreather mask and you can be giving high flow oxygen to this patient at approximately 12 liters per minute. The objective is damage control, salvage whatever you can. Then IV fluids are anyway to be given to this patient. Why? Because when the patient is breathing very fast, respiratory rate is increased. Like when I'm talking to you, I'm also breathing simultaneously. There is loss of water from the body in the form of water vapor. We all have insensible losses. You very well know insensible losses can be in the form of sweating. Insensible loss can be in the form of water in the stool. But one of the important insensible losses is the evaporation of water while we talk and while we breathe. In this person, since the respiratory rate is on the higher side, so insensible losses are definitely increased. So the textbook says that IV fluids should be given to this patient to manage the dehydration component. You don't need to give too much of IV fluids because anyway there is a alveolar edema present in this patient. But at the same time, he says do not leave the patient to high and dry, in a sense that you are not taking care of the increased insensible losses in this patient. Then we will be giving steroids to these patients. Now, why do you give steroids to these patients is mainly because of the CNS involvement. You see, whenever there is a development or damage to the vasculature of the brain, the microvasculature of the brain, there is a cerebral edema. So I want to reduce the vasogenic. I'm not talking about cytotoxic. Cytotoxic cerebral edema seen after stroke, there you use mannitol. But for vasogenic cerebral edema, I will be giving steroids for these patients. And then I'll be also using heparin. Now your query will be, sir, heparin is used in pulmonary thromboembolism when there are clots. Here there are no clots. You are yourself saying there is fat globules and you are giving heparin. Well, my dear friends, heparin, I agree to the fact, contributes to antithrombotic effect. Antithrombin 3 activity is upgraded, so it neutralizes the development of chances of a clot. But if you read pharmacological books, they also say a very interesting fact that heparin has an anti-lipemic effect. So it is going to dissolve the fat globules. Looks a little far-fetched, but true. Heparin not only has an antithrombotic effect, but it also has an anti-lipemic effect. And because fat globules are the villain in this case, so we need to handle them by using heparin. It could be plain heparin or it could be a subcutaneous low molecular weight heparin shot once a day for convenience purposes. We also need to prevent deep vein thrombosis in these patients because anyway they will not be allowed to move. And if somebody is already having a fat embolism syndrome, and God forbid if it does DVT and then the clot embolizes to the lungs, it's a double insult. So I want to prevent deep vein thrombosis by using compression stockings over the legs of the patient. But at the same time, I also want to say that since he is having fracture of the lower extremity, so this may not be possible in some cases. Like in case of polytrauma, there might be trauma to both the tibia and both the femur of the patient. In those circumstances, this approach point number 5 may not be feasible as well, and then the chances of DVT will dramatically increase, though I'm trying to reduce that by using heparin in the patient. Also, these patients, because of their medical illness, will be predisposed to stress GI bleeding. So pantoprazole would be routinely prescribed to these patients intravenously. This would minimize the chances. So good supportive care, good nursing care can definitely ensure some chances of survival for these patients. And as far as the mortality of this condition is concerned, yes, the mortality is substantially high, goes up excess of 50%, but that depends upon how early and how late it was identified, and also whether supportive medical care was provided to the patient or not. But if we are able to identify early, if we are able to manage, we have seen cases where the patient was able to pull through this, I would say, catastrophic phenomenon and was able to come out of the mayhem. One of the important differential diagnoses I again want to highlight for this patient would be pulmonary thromboembolism, and the second one I mentioned was pulmonary contusion. And the third differential diagnosis for this I can say is simply that you see, because the patient is comatose, any comatose patient can develop aspiration pneumonia, but then at the same time aspiration pneumonia is unlikely to be having petechiae. Aspiration pneumonia can definitely be contributing to development of damage to lungs. So hypoxia will also contribute to CNS manifestation. So they have to be kept in mind. You need to keep an open mind for this. And one more disease I'll write before you, where you are having a combination of lung findings as well as CNS findings. Lung findings, respiratory distress, CS finding, coma. This disease has been discussed by me in the kidney topic, thrombotic thrombocytopenic purpura. In this thrombocytopenic purpura, the CNS manifestation is the development of acute ischemic stroke. So do read up the TTP diagnosis as well. The list that I made before you is differential diagnosis of fat embolism syndrome. I repeat the fact once again, fat embolism has CNS issues as well as lung issues. A disease which can be having both CNS and lung issues is thrombotic thrombocytopenic purpura, and the subsequent ones that I've written, in these conditions like pulmonary thromboembolism and pulmonary contusion, the hypoxia of the lung disease can also contribute to altered CNS mentation. And similarly, aspiration pneumonia, the patient was, let me say, comatose because of some brain tumor, and then he aspirated. So anyway, I mean, the combination of two findings would still be present, but that obviously can be ruled out by taking proper history of the patient and deployment of the GERD criteria. And fat embolism is anyway, as I highlighted, a catastrophic event. I have seen doctors fumbling for words in front of relatives. In fact, I myself would be fumbling for words to explain why there's a sudden deterioration, because they don't understand the technical stuff. And that is the reason why lots of time, the violence component occurs, that the relatives will say surgery was not done properly. It's not that any surgeon will do some negligence during surgery that subsequently fat embolism will occur. If it has to occur, it will occur. I told you the figures also. Figures can be as much as 90%. It is just that the patient's body is able to handle the stress. And if it's not able to handle stress, then obviously in 2% cases, the fat embolism syndrome will occur, where the mortality rate is substantially high as compared to other medical diseases. So anyway, a good input and awareness of the disease has to be kept so that you are able to solve the questions and are able to evaluate the history component properly. Thank you so much for hearing me out, and keep on working, keep hammering guys, and you'll be able to achieve your dreams.